Now, finally, the master of masters, Professor Dr. Stephen Ide. He is a periodontist and an oral surgeon who has done PhD in the field of laboratory medicine. Dr. Ide has been conducting the product development department and clinical preclinical research in Ide Dental Group of companies for the last 20 years. Dr. Ide's main field of research is adaptation of the bone, the repair of bone, and development of techniques and devices for immediate loading of dental implants. But before he starts, may I request Dr. Ide to please come in the center of the stage once. On behalf of whole house, I wish you a very happy birthday. And friends, I should pass you this information that 24th of July, we celebrate the Strategic Implantology Day in honor of Dr. Ide. Please continue, sir.
Thank you very much to Dr. Vivek Gaur. He makes me work every year on my birthday. Whatever day of the week, so always work. Yesterday in the panel discussion, we were talking a little bit about what to do against overloading and how to control the forces. Now, Dr. Spiridonov just showed you some prosthetical concept, how to avoid overload on single implants or in areas of the jawbone. He mentioned the polygon and so on, but still there are situations when it is advisable or when we need something else in order to avoid parafunctions and in order to avoid too high forces. As you may have experienced in your clinical practice, there are cases where patients have not a lot of bone or even have very low bone quality, and in relation to that they have very high chewing forces. We can see this and palpate this first of all in the masseter muscle and in the temporalis muscle, and in such cases we can include botulinum toxin as a therapy. Botulinum toxin, of course, is used also in other maxillo-facial conditions. Now, some doctors are a little bit afraid because the word botulinum toxin it includes this word toxic, so we think, okay, we cannot do this. But in fact, botulinum toxin is not really toxic, as this article shows. The abstract goes, Paracelsus contrasted poisons from non-poisons, stating that all things are poisons, and there's nothing that is harmless. The dose alone decides that something is a poison. So within the last 100 years, they say the perception have changed, and I will show you now some applications which are useful in our field. The publications which our group has handed in, this is first of all the textbook, Principles of BY, there's a chapter on that. Then there are 2 articles on the therapeutic and the prophylactic use of botulinum toxin in dental implantology. There is a review article in O Journal 2007 written by Professor Konstantinovich and me. So this is available on the use in the field of immediate loading. There are, of course, other uses of botulinum toxin in the maxillofacial field. For example, a group around Sang Ho was using botulinum toxin in order to reduce the fractures of the fracture plates, and they found that these fractures were down to 25% compared to the group without botulinum toxin. So there's a lot of secondary literature, and we know today that the injection of botulinum toxin into the masseter muscle can give a real strong relief to myofascial pain. The patients who have chronic pain, chronic bruxers, or chronic pain patients without bruxing profit a lot from this therapy. And maybe you just take the pictures, or if you want to read this literature, so there's a lot around, and you can Google this in PubMed. In this article, it's mentioned that this botulinum toxin can be given several times. So I agree that at least 5 or 6 weeks, or better 8 weeks, have to be in between 2 injections in order to have the full success. So sometimes it is necessary to give this drug more than once. So therapeutic applications of botulinum neurotoxin in the head and neck disorders, another review article which I recommend you to read. So they describe the role of botulinum neurotoxin in the management of facial pain. Typically, it's the patients which are bruxing, which are very tense also from their personality, which have those problems, and we can really help them a lot with the single injections. Also, I want to remind you of the great-grandfather of occlusion and mastication, Professor Gaber, who had been teaching in Zurich University. And he writes, not always bite-taking leads to a positioning of the joint into the joint-centric. In some cases, we have to accept that the joints relapse into joint-centric only weeks or months after the incorporation of the finished prosthetic workpieces. We actually have the same problem, and if this happens on immediately loaded implants, we can see in some cases that our prosthetic construction, that the implants are getting mobile, and this mobility is caused by overloading of the bone and the interface to the low transmission areas of the implant. Professor Gerber writes that even with intricate techniques and maximum effort for bite taking, we may get wrong results, especially in non-relaxed patients, patients who simply can't be relaxed in bruxers, and in patients experience chronic pain for whatever reason. Those patients may benefit strongly from the therapy with botulinum toxin, according to our experience, because pain reduces significantly, muscles relax, the muscles relax, and TMJ may reposition themselves in the proper situation. We cannot really know which patients are going to be affected. That's why I recommend, after doing these reconstructions and incorporating the prosthetic workpieces, that you control the patients. When we have patients coming from abroad to our clinics, we treat them in the first 3 days. Of course, they get the prosthetic workpieces within 3 days. Then we are adjusting the occlusion and the mastication and the protrusion. And then we try to see them again on day 4, 5, maybe day 6. So from the beginning, we tell the patients they should come for a week so that we can control the situation better. In the book Principles of BOI, which came out in 2004, there is a chapter about secondary overload. In a situation in which the spatial position of the mandible changes as a result of altered muscle function, may be defined as a secondary overload. These situations occur usually within the first months after inserting a restoration. Secondary overload situations develop naturally while the masticatory function is undergoing an adaptive process. It's not the result of incorrect treatment, but of unexpected muscular reaction. So secondary overload is mainly due to changes in the muscle functions. It's not so much due to changes in the morphology of the mandible, which we see, of course, later on also when we restore the cases, when we give proper occlusal table, masticatory table from 6-6 patients who didn't have this before. In general, we have to accept that the angle of the mandible opens throughout life. This doesn't change. Because we put the implants, and as a result we are going to have typically early contact on the distal abutments. This is what we have to control. We typically ask the patients to come back for control after 3 months. I'm sorry, this picture this doesn't work here. This morphs, I'm sorry. This is an old picture out of the textbook of Principle of BOI. We have too much light here. We don't see too much. On the left side, you see a disc implant with a polished surface, and you see a lot of black around the disc plate. The disc plate has caused overload to the surrounding bone. This is what we call an overload osteolysis. This is not the same thing as a periimplantitis. Periimplantitis is connected to infections coming down the vertical shaft of the bone. And in this case, this is a very old case, we took off the prosthetic construction, so the bridge was removed, and we left the implant in for healing of the bone, and you see that 6 months later, this implant is again quite good integrated in a bone with a higher mineralization. So this is what we did at that time. Now, of course, if we work in immediate functional loading with the BCS implant today, and if there are only implants, and many of them are overloaded, I mean the bone is overloaded around the implants, it's not a good option to take the bridge off and to tell the patient not to chew anything. So the only way that how we can attract this problem is that we inject Botox. Botox can be injected into the masseter muscle and maybe even into the temporal muscle. So in order not to remove the prosthetic construction, we can unload the implant with the help of botulinum toxin. So it's a way to unload it. In our country, so in Europe, we have two brands. One is Dysport and one is Botox. Botox is probably the more popular product. As mentioned, we have a prophylactic application in combination with immediate functional loading. So we will administer the VTX before inserting the prosthetic construction. Typically on the day when we operate, we also give the Botox in the end. So it takes about 3-4 days until the Botox works, so that the muscle is down, and in the meantime the prosthetic work piece is manufactured in the lab, so that when we administer it, when we incorporate the bridge, we already have a significant lowering or a complete elimination of the forces of the masseter muscle, and if you want to inject also the temporal muscle, it will be the same. The good question is how can we determine or how can we sort out the patients which should be treated prophylactically? This question has been discussed a lot. There's no answer. I cannot give you the answer. I would say it's never wrong to give Botox, but this is, of course, too progressive, this idea. If the patient has a unilaterally strong masseter muscle, it's definitely advisable to inject in such a case. If it's strong on both sides, probably also. The other option that we have to reduce the forces is, of course, regular, very, very regular control, or to insert more implants, to increase the number of implants. Therapeutic application. If there's a palpable or visible lateral mobility of the implant-borne bridge on the strategic implants, then it's the right moment to do it. I have seen also cases developing very well if there was vertical mobility. I want to remind you that in the consensus on BOI, which was updated last time 2018, it's on the implantfoundation.org website. The vertical mobility of an implant is listed as an indication for the removal of the implant. It's of course clear if the implant is moving vertically through the corticals, then there is no traction between the implant and the cortical, and this will lead to a situation where this bridge becomes more and more mobile. But if you undertake an attempt of treating this with Botox, I have seen a number of cases where the bridges became really stable again, and this only shows us the enormous regenerative potential of a cortical. Of course, an implant which is, according to this theory of osseointegration, an implant which is anchored in anchor is already the wrong word. An implant which is positioned in the sponge's bone, if there is an overload and this implant is mobile vertically, you can do what you want. This will never be good, and it will never be good because the implant surface is rough, and only for a short time, such a vertical mobility of two-stage implants are sterile loosening. Very quickly, it's going to be non-sterile losing, and then there is no way back. Keep in mind that if you use the strategic implant in a transcortical manner, so that the implant is peeking out of the second cortical on the other side, the implant is in direct contact with the periosteum, and the periosteum will give informations of pain to the brain. So this, even a slight mobility, may it be a lateral mobility or vertical mobility, is then transmitted to the brain. Well, this is very important information for the patient to come or to call us, and then we can very early adjust the occlusal and masticatory situation. But of course, there's an underlying problem, and I give you a list now of these underlying possible potential problems. The increase of the vertical dimension should be done in order to prevent the anterior pattern of chewing and to reduce bruxism and chewing forces in general. We should, if possible, increase the number of implants supporting the construction. So this increases, of course, the amount of cortical anchorage. And if we put implants, new implants into the game, of course they are engaging into fresh cortical which has not been suffering from overloading, which is not in a little bit osteolytic situation. Keep in mind, if you would include more implants and you would not give Botox or botulinum toxin, then the danger is that the new implants would also suffer from the overloading, because the old implants are not contributing a lot to the stability. I mean, this is one of the principles of case rescuing, when you leave mobile implants in because you think they will reintegrate or that the mineralization in the interface will go up. If you do this, then you have to insert enough new implants into stable cortical regions so that the bridge is stable by itself only on the new implants. You can leave some mobile implants in and of course include them into the prosthetic construction. But if you decide for such a change, for such we call wheel change, if you decide for this, then the new implants by themselves have to be stable enough. This means you have to put minimum 8 new implants in the upper jaw, and you can leave 4 or 5 old implants in. So the new ones have to be stable enough, or you give Botox, you really reduce the forces. Another point, point 3, is here the reduction of the size of the masticatory surfaces, and we have to create an equal amount of such surfaces on each side. We have to reduce the cusp size in the upper premolar and molar region, of course, so all these lateral forces have to be reduced so that the lower jaw can slide easily against the upper jaw. We have to adjust the FMP on both sides in many cases. So if the patient has developed a unilateral pattern of chewing due to unequal IFMP angle, this must be corrected also immediately. Also we have to try to reposition the joints into the real joint centric. The primary aim at this stage of treatment is to maintain a fixed dentition, so we want to keep the bridge in. We want to keep the patient chewing on the bridge, on the implants. We usually avoid removing of the fixed bridge as long as the bony interface in the area of the load transmitting implant parts has not recovered. So we have to wait half a year until we exchange the bridge, even after everything is stable, because the danger is that some implants are still unstable. It means this interface of bone to the implant is not yet highly mineralized or mineralized high enough, and the activity of removing the bridge, cutting the bridge down, is enough to damage the bony interface. So I recommend that if you go for maintaining the bridge inside and Botox and maybe adding a few implants, don't take the bridge out at least for half a year. There are a number of possibilities to add implants to the prosthetic construction without removing it. So there are a few articles about this, and you can find this all on the internet. There are a number of muscles which we can consider treating. So the masseter muscle, vertical part and oblique part should be treated. And if you feel that the temporalis muscle is too strong, you treat this one also. Keep in mind that this molecule, botulinum toxin molecule, is a very big molecule. It's quite sensitive. So you have to administer carefully this milliliter of saline solution into the vial where this dried substance is in. You are not allowed to shake it. You just pour the liquid in and you soak it up with this insulin syringe, and then you can perfectly dosage it into different parts of the masseter or into the temporal muscle. So if you buy 300 or 500 units of this port, you can distribute this very precisely into the different parts of the muscles, those parts of the muscles which are affected. Typically, on the oblique part will be injected from inside the mouth, and this part here will be injected from outside. Both is actually very easy. If you inject from outside, you will first of all palpate the muscle. So where is the strongest part? Typically, we make a few dots. So that we can remember this, and the thickest part or the most active part of the muscle should be in the center. And then we do this injection. We go with the needle down to the bone and then a little bit back so that we are in the muscle. If we inject from inside the mouth into this oblique part, the anterior part of the masseter muscle, there's no bone to go down to, so we keep the muscle well, either against the dentition or between two fingers, and then we just inject into the middle. The medication which I have most of experience with, this is this port. We are using this for 15 years. Basically, well, there are not so many potential side effects. One side effect is that if you miss the muscle, then the Botox is going to be in the interstitial tissue. The same will happen if the patient kind of starts massaging right after receiving the Botox. That's of course very bad. So then some of this medication can be pressed out of the masseter. It will be in the interstitial tissue, and it will start to paralyze other muscles, mimic muscle, buccinator, and so on. So this should be avoided. You have to inform the patient about this before. So because I saw one case where the patient just jumped out of the chair and was massaging. Of course, she couldn't smile for 9 months. So she had new teeth and she couldn't smile with them, which was bothering her. But the bridge became stable, and after this, everything was okay. The mechanism of action, it's easy to describe. Botulinum toxin acts only on contractile tissue. It binds competitively to neuromuscular synapses and prevents the transmission of neurological signals. This leads to the destruction, atrophy, or at least dysfunction of many synapses. Some of the synapses of the muscles may stay active or undamaged, and others recover. This result it goes together with an increase of chewing forces after about 2 months, and 90% of the forces compared to before treatment can be reached. So every time when this treatment is repeated, the resulting forces of the muscle after recovery are about 30% lower than before treatment. So this is basically the scheme. There's a point missing. So this is the first injection. Then after 2 months, we do the next injection. After 2 months, we do one more injection. Actually, mainly we do 2 injections, not more. And you see how the resulting total chewing forces are going down. So we are here then close to 50%. But keep in mind, this is an estimation. 50% is an estimation out of the experience. If we decide to use this port, and there's a pack available with 300 units, so we give to the vertical part 75 units, to the oblique part 75 units, and the same, this is the left masseter, that's in the right masseter, so totally we are using up this pack. In the old times, let's say 10 years ago, there was no 300 units available, there was only 500 units. Also at that time we were using the whole pack for one patient, because there's no point to give it to several patients, but we see today that the 300 can be also enough. The dosage for Botox is different. So as far as I remember, there's only 100 units Botox, but the way how this is produced, I mean, as a result of the galenic process, it seems that less units of Botox give the same result. In the temporalis muscle, which we don't treat typically, it's necessary to treat all 3 parts with these 10 units of Botox. So far, I have never done this. In 15 years, I've used only the masseter muscle for the force reduction. So why are cortically based dental implants construction getting stabilized after the application of botulinum toxins? The reduced or eliminated masticatory forces allow the regeneration of cortical bone. The immunization of the cortical peri-implant bone goes up. That's what we want. So this is what will then stabilize the implants. Those of you who have not done this, who have not seen this, cannot imagine what a big difference it makes if there's Botox or if there's no Botox. After you've seen this really happening in your clinic, after you've seen how the bridges calm down only in a few weeks, you will understand a lot more about the regenerative potential of the cortical bone and why I prefer to do cortico-basal implantology over everything else. So the sponges bone is for us not a reliable partner. I'm not saying that osseointegration doesn't work, but definitely cortico-basal implants work. And if there is a problem, if there's overloading, we have no chance to do anything for an osseointegrated implant or for an implant in the sponges bone. But we have a lot of possibilities to manage the situation by bringing the masticatory forces down. It is necessary to distinguish between the peri-implantitis and overload osteolysis. This point is very difficult to explain to the two stages because it reflects their experience that if something is wrong with the implant, there's always an infection. So also the word peri-implantitis, itis, meningitis, hepatitis, and so on, indicates that there are bacteria involved. I'm not saying that there are no bacteria involved, but the bacteria definitely are not the cause of the problem. The bacteria are rather utilizing the situation, that the defense is down. The bone in peri-implantitis cases very often is disappearing or shrinking, or how you may call this, due to a lack of function, due to the fact that the big implants diameter are preventing the transmission of macroterritorial forces in the area of the first cortical. There are a lot more reasons, and unfortunately the research in the area of the peri-implantitis is going in the wrong direction for the last 20 years, and I have good reasons to admit that the universities have been intentionally misled not to do research in the right direction, because if they would do it, they would very soon question the designs in two-stage implantology. So this doesn't happen, and I don't think that people simply are stupid. They are highly intelligent, but they are brainwashed and they don't investigate in the right direction. So for the conventional two-stage implantology, this distinction is useless also. I mean, to distinguish between peri-implantitis and overload osteolysis, because rough implant surfaces of mobilized implants are almost instantly infected. So due to this, the pathology is not reversible nor treatable, but the situation is completely different in cortico-basal implants because we are anchored in the second cortical, not in the first cortical. We don't depend on osseointegration in the sponges bone, and there is virtually impossible to infect 2 millimeter diameter polished implant. And it's simply like this. So the expected results, clinical results of the application of botulinum toxin in the masseter, there will be a significant reduction or even elimination of muscle forces, elimination of bruxism, relaxation of the masticatory system. So this will lead to a general pain reduction in head and neck. This is one of the purposes we want, to stop the patient to be so tense. We will provide the possibility of reimmunization of peri-implant cortical bone areas, stabilization of mobile prosthetic workpieces, reversal of overload osteolysis, and the elimination of pain of periosteal origin. I just explained this periosteal pain on chewing. As a result, this goes away as a result of the regeneration of the cortical and the stabilization of the prosthetic workpiece. So if you look, there are two mechanisms how pain is tackled, why pain goes away. So first of all, general pain reduction in head and neck. This is of course appreciated by the patient. and elimination of pain in the periosteal region. So after 1 week or 10 days, typically the patient can start chewing without pain, or at least with less pain, and then we have to make prosthetic adjustment, and we can manage the case. I come to the conclusion. The application of botulinum toxin reduces or even eliminates the forces of the main chewing muscles. It is mainly used for masseter muscle, for its vertical and oblique part, depending on which part of the muscle is hypertrophied. So this you can palpate. It takes about 4 days until the inactivity of the muscle can be felt. After about 2 months, the action of the drug vanishes, but chewing forces will not reach pre-therapeutic values. In my experience, after using this drug more than 15 years, the treatment is safe and effective. It is very useful for stabilizing mobile cortically anchored basal and cortical-basal implants. Remember that we were starting to use this in combination with the BOI implant. I mean, there were basal implants, lateral basal implants. Huh? The indication for the prophylactic use have not yet been explored, so there's no border that would tell us, look, this case we have to apply this drug prophylactically. However, we assume today at least the following: botulinum toxin makes treatments and immediate functional loading possible in cases when the quality and quantity of bone is low while palpable muscle forces are high. Thank you very much for your attention.
Thank you, Dr. Ide, for a very nice presentation. People were eagerly waiting for this presentation since morning.
Me too.
I'll request you to stay on the stage for a while, please.
A big hand, ladies and gentlemen, once again for Dr. Stephen Ide for such an interesting and a beautiful presentation.